In this final segment, we're going to kind of step back and try to look at a broader picture of what are the opportunities and challenges and considerations for using encounter data. I, in graduate school, really enjoyed the analyst role, and I know we've got a lot of analysts on the call, and a lot of what we do as analysts is kind of parse between some very fine details that we may move the needle a little bit, but probably what's I'm grateful to work with colleagues that kind of also help me remember to step back and look at the big picture and where the data arise and what they're describing. Sometimes that's much more important for inference than kind of some of our tiny details that we're worrying about. Not that the details aren't important, because like I said, I feel like they're very important, and that's what I tend to fixate on. So when we think about this segment, we really want to just look at what are the primary strengths and limitations of using Medicare Encounter data alone or in combination with other administrative data, and look at some key distinctions between encounter and fee-for-service that may influence study design and analysis. Some strengths of using healthcare from the Medicare program. This is a large and very representative population. If you're looking at people over 65, this is, it's 98% coverage, 64 million beneficiaries in 2019. And now that we have Medicare Encounter data, we can really look at the whole population. So, and even some subgroup analyses, for conditions that aren't incredibly common in general, we will have maybe a sizable population if we look within the Medicare program. So it's very useful. You've seen this a few different times, but because of this split, if we rely on just fee-for-service, we'd be missing a good chunk of the Medicare Advantage population. So it's very helpful as we go through to be able to add the encounter data. It's wonderful that it has become available. Now, there's strengths associated with both fee-for-service and encounter data. We have really good, reliable, and valid data. It's, age and date of birth, sex, race, place of residence, the date of death. Now, cause of death is limited with the NDI, but we do have, the date of death information is also very good. It's, connected with federal benefits, so it's important to be accurate on that. And we have, really good quality clinical data about services that are covered and are used by enrollees. We have good dates. Dates are important for ensuring that someone's supposed to be covered during that time period. Diagnoses and procedures are important for getting accurate payment. Source of care, provider of care, those are all going to be reported for both encounter and fee-for-service data. And we have this ability to link to external data. Now, depending on your research study, definitely get in contact with ResDAC about if you're interested in linking, but you can link to census data. Sometimes people even do a link at the zip code level to summarize census information. Disease registries, there's a SEER Medicare linkage that's very active. You can link with other payers, the Veterans Administration or commercial payers. If you have identifiers and you're willing to enter into a data use agreement and can figure out how to do the linkage, and we can help you with that. You can have this great ability to link out. We also have assessment data, minimum data set, as we've talked a little bit about, from nursing homes, and surveys. The health and retirement study is linked with Medicare data, the Medicare current beneficiary survey. There are a few other surveys that are linked. So we have great ability, and that's not something that's unique to fee-for-service or encounter data in general. The linkage can be done. Now, there are limitations to both fee-for-service and encounter data. We're limited to Medicare covered and paid benefits. So some services aren't covered if it's not indicated. So indicated means sometimes a service will only be covered if they have a certain diagnosis. If it's a non-FDA approved drug, we may not have coverage for that. Part D plans have formularies that they will use to pay off of. And then for things like immunizations, we think about COVID vaccinations. To the Medicare covered them, that's great. But to the extent that someone may have gone to a mass immunization site, for example, and didn't need to show a Medicare card and their Medicare data wasn't collected, we may never see a claim for that data. So vaccinations have sometimes historically been difficult to measure. Oh, and someone was asking about linkages. So the current HRS Medicare linkage, I don't think has encounter data, but that's something to look into. And then MCBS and encounter data, that's something else that maybe hasn't been done yet, but it's definitely doable given the information that we have. So if we could request linkage, I think that's something that you could definitely email ResDAC at umn.edu about, and we can talk about options with that. So moving on, we talked a lot about this earlier. We're limited to what diagnoses are reported on the claims, and they may be under or over-reported. I think the point was made in the chat. Upcoding is a thing both for fee-for-service and encounter data. Fee-for-service claims are paid, the inpatient claims, and are paid based on the diagnosis code that's reported as, with them. So sometimes there is incentive to be very thorough, very thorough about adding diagnosis codes. And in the encounter data, there are chart reviews. We also have to note that this is a record of care received. It's not intended to be a health history. So we do see, there are 25 claim fields collecting diagnosis data. We can see 25 diagnoses. We can have a lot of information about possible comorbidities, and that's a great wealth of information, but it's not necessarily an intention of the billers to give a full health history. It's the intention of the billers to to bill for a service. So we're not looking in a medical record, we're looking at administrative claims data. They also have to be conditions that are reported on a service claim. So hypertension, depression, diabetes, mild cognitive impairment are often underdiagnosed. They may not be picked up during the visit, and then they wouldn't be necessarily added to the claim. And then, of course, this isn't a date of diagnosis, it's a date of service. So we apply algorithms to say when we think a diagnosis began, if they hadn't had it for the 12 months prior, and all of a sudden, if we're thinking about incidence versus prevalence, we have to note that it's just documenting that a service occurred and that they happen to have a diagnosis at that point, but this isn't the day that their condition started. It's also a record of care received and not necessarily care needed. So I've worked in the cancer space a lot. If someone has a cancer recurrence, they were treated and they went for a while without having any issues, and then they had a recurrence. We may not see evidence of their recurrence because they may have continued to have carry a cancer diagnosis on their claims as a comorbidity. But we wouldn't necessarily know that their cancer had recurred if they chose not to treat it at that point. And so we see what care has been received, not necessarily care that they actually need to have, or if they have been given options by their physician and choose not to use those, we wouldn't see that either. There are algorithms, and this is the reason that we have algorithms to measure variables of interest. When we ask for these data, we don't get a, yes, they had heart disease, 0-1 indicator. We have to use the information that we have to infer. So just a reminder that either fee-for-service or encounter data, their primary purpose is not necessarily health services research or clinical outcomes research, and we have to keep that in mind as we go through. We also don't have physiological or behavioral data necessarily. So, it's not a medical record. We're not getting information on body mass index or blood pressure numbers. We don't have their heart rate. We also don't have test results. So we can see that a test maybe was performed, but we don't see what the result of that test was. And behavioral information like whether or not they smoke or use alcohol or exercise, we don't have that. Now, smoking, you may say there are diagnosis codes related to smoking. Going back to the previous slide, that's one thing where we can see it will be reported more often if someone's receiving a tobacco cessation therapy. If they've chosen not to receive that, we may not ever see that they were a smoker. So definitely underreported when we're looking at administrative healthcare claims data. So for both fee-for-service and encounter data, the coding of procedures also varies by care setting. So we have inpatient care using ICD classifications. We have carrier using CPT codes, HCPCS codes. Outpatient care is going to be a mix of CPT codes and revenue center codes if we want to drill down into the service used. And there's a less than perfect crosswalk between ICD codes and CPT codes. So it can be tricky. You would want to make sure that you're being comprehensive in what you're looking for. And you're just going to have to kind of cope and be very thorough as you're looking through. And there's also, sometimes we don't have enough detail to really understand what's going on clinically with someone. So knowing that someone has congestive heart failure doesn't tell us, when it started. Again, that might be something where we try to create an algorithm, but it also doesn't tell us how severe it is. Is it stage 4, class 4? Their cancer stage, by and large, not included in diagnosis code information. So that we may not be able to say whether or not a particular treatment was appropriate because we don't know where they're at in their disease process. Also, many drugs and procedures might have multiple indications. The Part D event file, it's been available for Medicare Advantage for a long time, but it's never carried diagnosis codes. So it's great that we have encounter data now to kind of supplement, but if someone is taking antidepressants, that doesn't automatically mean that they have a diagnosis of depression. There are other things that antidepressants might be used for. So we try to do our best and write algorithms to say, if we see this, we suspect something. But a lot of it is a little bit of finesse and maybe doing sensitivity analyses and all the things that we've kind of talked about this afternoon. Now, similarities between fee-for-service and encounter data, the file structure is very similar. You're going to see a lot of similar fields. Now, the join key is one thing that's encounter specific, but we do have claim IDs in the fee-for-service data. The dates and the DRG fields, while their name might be slightly different, the information that is included will be very similar. And we have the ability to link across file types. So for all of them, when we get a beneficiary ID, and as we mentioned earlier, that's specific to your project, your DUA, you can get that to link encounter and fee-for-service. You can get it to link, so you can follow a beneficiary, between encounter and fee-for-service if you need to. But also you can see after an inpatient stay, how long until they have a clinic visit. You can follow people over time and across different care types. So these are really, really beneficial to have on these data. Now, differences that we will see between fee-for-service and encounter, of course, we just heard about the lack of reimbursement data. We don't have payments to Medicare providers on the encounter data side. And then the structure of the payments to providers vary by plan. And if you're interested in clinical care, you might say, I don't care that there aren't payments. I don't want to measure them. But knowing that the structure of the payments varies might give you insight into the fact that different plans seem to have very different rates of a certain procedure, and it may be an artifact of how the provider is paid. So that's another thing to worry about with encounter data. Also, Medicare Advantage organizations, because they have variation in payment, they may pay for some services as a bundle. It's not impossible in fee-for-service data. This also happens, but it may happen more with Medicare Advantage. So, if there's a capitated payments, or if there's some sort of bundling, if you say I'm going to pay a provider for all the care surrounding a hip fracture with the hopes that that encourages the provider to be very efficient, that might look like one payment to a provider instead of capturing all of the individual services that were provided. And also, as we've talked a lot about, we may need to do some deduplication if we're counting services. Again, it's many of the services you're going to find one service record, but for the ones that we don't, we are going to have to try to look a little bit harder and figure out which ones we might want to keep if we're counting. We also have those chart reviews to increase the number of records per service that we see, and also the diagnoses. And that requires one more decision in terms of whether or not we want to keep the chart reviews when we're creating a measure or not. We also have the fact that Medicare Advantage plans offer extra coverage, and they vary in the offer of extra coverage. And so we do see these in the encounter data, but again, like evaluating their completeness, we really need to find some other validation source in order to get an idea of how complete the data are. So given those differences, when we're creating analytic files, we have a fee-for-service, our flagship workshop that, it's been running for a long time. And the reason is because these data are still very complex. And so there's still a lot of things that need to be done with fee-for-service. And then Encounter will parallel that. We're going to need to make sure we're applying maybe demographic or geographic inclusion or exclusion, or enrollment inclusion or exclusion at the beneficiary level. We have to go through and identify what we're interested in and create a flag for that somehow. A lot of times when we're creating an analytic file, we're trying to maybe take all of the records that we're finding and all of the various claims files and roll it up to one line per person, perhaps. And so we're going to be needing to create variables based on what we're finding in those files. Encounter data is the same. We're doing a lot of the same things as we're working with the encounter data, with the added removing of duplicate records, which might be a little bit more of a headache. Now, I've never created an analytic file using administrative claims data where I just created it and then used it. It's an iterative process. You do your best in planning how you want to measure something. Sometimes you look and you say, I've worked with clinicians that have said, I feel like we're missing something. Sure enough, we go back and find out that we've missed a procedure code or something because they're like, that's not the right number. Analytic files, it's iterative. So once we've created it, we really have to do our due diligence and do some checks. Really, review what does the denominator look like over time, because there are some policy changes that might impact how people are included or excluded from our denominator. Less commonly, we might see changes in variables over time. Something becomes available that wasn't available before, and we didn't know. And so if we were just creating a global result, we might say, oh, it's a little lower than we expected. But if we looked over the years, we might find actually we weren't measuring at all for the first few years, and then suddenly it pops in. So it's really important to review things over time. And that's true of, when we're looking at not just our denominator, but our numerator. There are procedure codes might change. So you might be measuring something going along and it looks great. And then all of a sudden you have 0 because the procedure code has changed. And then policy changes. So how something gets billed might change. Oftentimes in fee-for-service, you will see this at a quarter. So it'll change on it's June 1st and it's different, or the federal fiscal year runs October 1st to September 30th. So when we see things that change in October, that's our cue to go and look to see if there's been some change based on the federal fiscal year. For the encounter data, again, we're going to be doing the same thing in terms of looking over time, plotting by month and year to see, how well does our global result, if we're, at the end of the day, our summary result, does that match what we're actually seeing in individual months and years? Are there trends that we're picking up, or is there something that we've missed in terms of how we're measuring something that's changed over time? We're also going to want to, with encounter data, I think, do the added step of looking by plan to see, it looks like there's some variation in how this was billed by this plan. Some plans, it was mentioned, have more capitated type enrollment or payment situations, and that might alter what we're going to see in the data. So So we need to make sure that we're doing an extra step, probably. So final thoughts. The release of this data is great. It provides unique opportunities, and it adds a whole, almost a half, of the Medicare population back into the possibility for study. But they're not without challenges. A lot of the challenges are not unique to Encounter Data. They, any administrative healthcare claims data have these same challenges, but there are some that are unique. Learning from the fee-for-service and Encounter Data requires creativity and perseverance. I think we have to be, there may be setbacks. You kind of might want to have a plan B as you're moving forward. And when I say creativity, I don't mean like making things up, but you may have to say, we can't measure this directly. How are we going to measure this in a way that we feel very confident about what we're seeing? So with that, are there questions? We have a good lot of time for questions or anything we want to talk about. I see there's a question about when will ResDAC offer the next fee-for-service Medicare workshop, and that actually will be probably next calendar year. I don't have a date exactly, but we do have videos on our website that you could look at resdac.org/learn. And also feel free to email the help desk if you want more information about that. Let's see. So if you're looking at a diagnosis code for an acute condition, like an easily treated infectious disease, would it be less likely to be included in the Encounter Data versus fee-for-service if that ICD code is not likely to affect the reimbursement amount to the managed care organization? So I think the intention of collecting the Encounter Data is to have the managed care organization submit all the services, and that's, CMS wants to know how Medicare beneficiaries are using healthcare in order to do some of that quality improvement and care, what needs to be covered, kind of thing. And so the intention is that they should be submitting all services. Now, their incentive to submit services does change based on the risk adjustment, but hopefully they're putting systems into place that kind of, they're trying to be as comprehensive as they can in terms of submitting. But it is something that we worry about a little bit when we're, we want to consider what's driving the data, I think. And in terms of access to the slides, let me give you access to the course page. You can click on that link, and the course materials are within, if you click on links on that page, if you scroll down, there's an agenda, and you can either get them by segment or the access course materials gives you the whole packet. Let's see here, and then a question, is it possible to link fee-for-service and managed care data at the beneficiary level to identify beneficiaries who switch between fee-for-service and MA? So if you have a DUA that includes both populations, actually, in general, if you're getting the managed care, or sorry, the MBSF, and you haven't explicitly limited to fee-for-service, the MBSF itself should have both, so you'll be able to see. There are a few different monthly indicators that tell you. So there's an entitlement indicator that tells you whether or not they're enrolled in Medicare, and then there's and that tells you whether or not they're enrolled in A and B, or just A or just B, and whether or not they have. You can look at a state buy-in indicator and give you information about whether or not they're dually enrolled. And then the HMO indicator, you have to add that on top of the entitlement indicator. That will tell you whether or not they're enrolled in Medicare Advantage. So just the entitlement indicator doesn't tell you. You need to add the HMO indicator, and that will tell you. And just to note, some people might say, well, I thought A and B was fee-for-service, and really A and B is also managed care. So almost all managed care beneficiaries are enrolled in parts A and B. So just to note that if you're limiting to A and B, you're not necessarily getting information about whether or not they're enrolled in managed care. So any recommendation from ResDAC to use the combination of fee-for-service and Medicare Advantage data for a longitudinal analysis, taking into account enrollment switches or in and out between fee-for-service and Medicare Advantage. We don't have any explicit recommendations, and a lot of it will depend on your study. So, you know, the most brute force thing would be to say, I'm, you know, only going to include people that don't switch. Then you're probably going to miss some information about important people. In the past, when I was working with just fee-for-service data, we might do a survival analysis and censor people if they enrolled in Medicare Advantage. So there are some statistical adjustments you might be able to do in terms of switching people from one beneficiary to another, you know. And then a one-stop code book or data dictionary for CCW or Medicare data. So with the ResDAC website, we have our data. Let's see here. Our data are kind of spread out by the type of file that you're looking at. Although, you know, I think it's very well laid out once you do that. If you want a file that's that has, like, there's one Excel file that has lots of different information. The CCW webpage, they have a data dictionaries page. See if I can show you that. You can get a record layout and a code book, and that has all the files together. So the pro is that you can kind of get a good bird's eye view. And then the con is that, you know, if you really only care about inpatient, you're gonna, in the code book, you'll kind of be wading through variables that are from other files as well. But